I reached out to Quang Dai, and he tracked down that patient, my friend's brother, or my friend's brother, as a patient, and so thank you for your help. Yes.
Okay, I'm going to start sharing my screen and we'll get started. Can everyone see presenter mode? Oh, yes. Perfect. Good. Okay. So again, we are talking about sepsis, and as Dr. Dye alluded to, we're talking about some of the instances where we have to talk to our surgical colleagues. We're going to have two cases. We're going to go over kind of a renal issue that we sent out for the reading, and then go over some of the topics which we touched on last week, some of the complications and some of the nuances that you might have to reach for if your patients are not doing well with your resuscitation while still down in your emergency department. So our first case, we have a 27-year-old female coming in with right flank pain. She is tachycardic at 118 and does look a bit hypotensive and is febrile at 38.4, but sitting well on room air. And she is 70 kilos. And I'm sorry, I know there are not that many diploma candidates on with us today, so it's going to be kind of a lot of heavy lifting for a couple of people for interactions. What are your differential diagnoses when you see those vital signs and a younger female coming in with right flank pain?
So, serious flank pain suggests me to think about the kidney colic. However, she is febrile, so I must concerned about the pyelonephritis. So that is one. That is the first diagnosis. Secondly, I may want to rule out other serious diagnosis like bowel perforation and the cholecystitis. Yeah.
Perfect. I think those are very good. I agree with you. We don't want to anchor on one thing. I know I didn't give you a lot of information, but the differential is still pretty broad, even if someone comes in with that right flank pain. I agree with you. The right flank, we usually think about the kidney involvement, either pyelonephritis, possibly an infected stone, but also in that same area, live, the gallbladder. So any of those biliary tree pathologies that we learn about, the ascending cholangitis, cholecystitis, any types of hepatitis. You might even have to think about a severe episode of Fitzhugh-Curtis disease, any ruptured ectopic, especially in somebody who still is younger, has a uterus, and is hypotensive, could have blood that's irritating up in the right upper quadrant. Sometimes if you have a PE, that could be pretty severe, causing an obstructive shock, but you can get that referred pain down into the right costal margin. And same thing with severe pneumonia, if that's where your consolidation lives. So I agree with you. You got to think bigger than sometimes just in the abdomen. Let's move on. And going off of last week, we're going to kind of go over from that what the SIRS criteria are, going off of what the surviving sepsis guidelines are, moving more towards SIRS and away from QSOFA. Which of the SIRS criteria are standing out to you from her baseline vitals?
Tachycardia.
Thanks, Shakira.
You're welcome.
So if we look at it, it's like we talked about last time. It's almost all of them. So she's tachycardic. The patient is febrile. Luckily, the respiratory rate isn't greater than 20, but and statting well. I didn't give you, any her white blood cell count yet. And then pushes her into septic shock because of the hypotension. So getting a little bit more information is that your patient looks ill. They're writhing in bed. They're holding a vomit basin, but going through your ABCs, they're speaking normally in full sentences. They're breathing. She's not in respiratory distress, and she has clear lungs when you examine her. Circulation, she feels very warm, but she's got good distal pulses. So that's reassuring despite her being hypotensive. So again, we have a 27-year-old female is here with 2 days of right flank pain with urination, and now having chills that have worsened. Initially, the flank pain was intermittent, but now it's constant, and is here also with nausea and vomiting in addition to the chills and fever at home. Her last menstrual period was 2 weeks ago, and otherwise the review of systems is negative. No history of surgeries in the abdomen. Your physical exam, I know I normally put things in red, but it seemed like everything was upsetting for the physical exam. So she's ill appearing, she has dry mucous membranes, but the lungs are clear, tachycardic, but no murmurs. She has the right lower quadrant tenderness to palpation to complicate your diagnosis. She does have some right CVA tenderness to palpation, and again, her skin is warm and dry. So with all of that information now, what interventions would you like to do?
She is showing signs of sepsis with very low blood pressure. So I will start with 2 lag ball IV access with fluid bolus with at least 500 millimeter in 30 minutes. Then in terms of test, I will take full complete blood count, coagulation panel, full metabolic panel, and blood culture. If I have time, I will take the urine culture as well before I start antibiotic. And then we will see if she is how she is responding with the fluid therapy, and deciding the next step.
Okay, perfect. So I heard the 2 large bore IVs, perfect. And I heard the fluid bolus, and we'll go off of the surviving sepsis guidelines and give her a 30 mils per kilogram bolus because she's young and looks otherwise healthy. I agree with you for drawing the blood count, the metabolic panel, blood cultures, a urine with a culture sent off, things that are important, as we talked about in any patient who has a uterus, either confirming that there isn't an intrauterine pregnancy with your ultrasound, or trying to confirm it with the urine, getting a blood gas and a lactate in these patients, and then kind of going off of to just starting targeted management. She was febrile on our appearance, so we can try to bring the fever down. That can help with some of the tachycardia. We'll give her an antiemetic to help with her vomiting. And we kind of touched on it last week about those guidelines, talking about the 1 hour and the 3 hour bundles, about trying to get your antibiotics in quickly. So I agree with you. And I think we have an idea of where her infection is just from the pretty good history. So at this point, I would start the antibiotic regimen, knowing that it's probably in the urine and likely either a pylo or an infected stone. And I know that it sounds like you guys have a slightly different drug regimen than we do out here after our conversations from last week. But otherwise, I agree with you. And then ultrasound or imaging. Unfortunately, her right lower quadrant tenderness does complicate things a little bit. You have to think about, is it her appendix? Is there a perforation on top of things? So unfortunately, patients can have more than one thing. So here are our labs. And looks like she's got a white count, but she's not anemic. She has a slight she's got metabolic acidosis, and it looks like her renal function, if we assume that it's normal, she has now an acute renal injury, and her urinalysis comes back positive for blood, leukocyte esterates, and nitrates, and she's got an elevated lactate. So kind of what we were thinking. You go ahead and you get a CT, and this is what you see. What does this tell you about what's going on with our patient?
I can see a slight enlarged right kidney comparing to the left one, and on the second, on the right, there seems like a stone that may cause the infection.
Yep, I agree with you. I'm seeing some stranding around the right kidney on both of the slices that have been provided, and it does look like there is some evidence of hydronephrosis on that first slice. If you had decided to grab your ultrasound first, this is what you have seen on the right side. What level of hydronephrosis would you characterize this as? If you either use a mild, moderate, or severe, or some type of scoring system, what would you say?
I may rate this rate 2 hydronephrosis.
Grade 2 hydronephrosis.
Based on for rate classification.
Sure. Okay. Yeah. So I've put in a couple of slides here just about, grading your hydronephrosis with your ultrasound. Out here, normally we do mild, moderate, or severe based on the cortical involvement and the degree of dilation of the calyces. But I agree with you, if you're using a different grading system, that one, I think might be, agree with you, either a grade 2 or almost a grade 3, based on which system you're using. Just for me, it looked like maybe half of the parenchyma was lost on there from the last one. But it really depends on your grading system of how severe your hydronephrosis is. So we reassess our patient, and she is still tachycardic and still a little hypotensive. What is your next step? Are you going to start a vasopressor? Do you want to try a second fluid bolus? If you decide to start a vasopressor, which one would you like to start?
I'm sorry. Can I know that this reassessment is was taken how long from the how long since she admitted, and how many fluids has we used for her?
That is a great question. So she has completed that 30 mils per kilogram fluid bolus, and we'll say your reassessment happens about an hour and a half after you've met her and she's completed the fluid bolus.
I will indicate vasopressor in for her. Maybe I will definitely use norepinephrine with the starting dose of 0.1 microgram per kilogram per minute.
Okay. Perfect. Yeah, so I agree with you. I think you can also sometimes, because she's healthy, and if you had your ultrasound and looked at her heart, she had a good squeeze and could tolerate a little bit more fluid. And it looked like she was slightly fluid responsive, but not as much as we were hoping. So I agree, this is somebody where we could start a vasopressor early to help get her a MAP of over 65 or a systolic above 90. And my first line, I agree with you, is norepinephrine. And as we spoke last week, if she continues to be hypotensive after you have started up titrating your norepinephrine, your next line after you've looked at her ultrasound and if her heart is normal would likely be vasopressin. for some of these septic shock patients. And then who at your hospital would you call for an intervention for source control for this patient? What service?
Since her infection is caused by a stone in the urinary system, I will definitely call surgeon, nephrourinary surgeon.
Okay, gotcha. So I'm not sure if it's this way at your hospital, and it definitely can differ by hospital systems. This would be a conversation also likely to rope in an interventional radiologist possibly, because the stone size looked pretty large, and it's to the point that it's now causing hydronephrosis and sepsis. And this patient may not be stable enough to go and get lithotripsy, and they may opt to try to put in a NEF catheter first, so an IR guided catheter to help with drainage before they can go in and start to try to remove the stone with lithotripsy. But that is, hospital dependent.
Yeah, I agree. In my hospital, the surgeon also do the nephro catheter.
Okay, so they do both there. I see.
Yeah, they do both.
Okay, perfect. So good. I'm glad that they do that. That's a lot more streamlined than here. And then where is this patient going? Where do they get admitted to for you guys?
I will admit her to the ICU.
Okay, perfect. Yeah. Other things that you can think about doing as your patient, isn't quite as responsive to your interventions that are second line things that have to be on your radar is, thinking about starting to place that central line if you have time, placing the arterial line for monitoring, these secondary things while hopefully your surgeons are getting ready to take them to the OR for source control, either going in and removing the stone, as we talked about, or placing the catheter. When looking more at this, additional therapy suggestions that the literature had was considering tamsulosin or nifedipine for large proximal stones to kind of help with the relaxation of the ureter to help them pass. But if they're larger than 10 millimeters, they're unlikely to pass even with those interventions. So good job. So this is we touched on steroids last week. So thinking about if your patient, you've tried your 2 fluid boluses, or you've been judicious with your fluids because they don't have great cardiac contractility, and you've started a vasopressor and they're unresponsive to your first vasopressor, and you're going on to a second one. This is evaluating the role of corticosteroids in septic shock, but this is in patients who are not currently taking any steroid regimen. So this excludes patients who are on prednisone greater than 20 specific comorbidities they kind of shied away from in this study. This evaluated 21 randomized control trials for individuals who were treated with corticosteroids. They did find a 7% reduction in at 28 days for all-cause mortality compared to no controls. But upon this large data review, they found that not all of the steroid interventions were created equally for sepsis and shock reversal. It did seem that methylprednisolone boluses were not as effective as compared to hydrocortisone boluses. And methylprednisolone boluses can actually increase the risk of mortality compared to a decadron or a dexamethasone bolus. So just being cautious about which medication you're using. And additionally, the concern we talked about last week with steroids is weighing the possibility of uncontrolled hyperglycemia in your patients who have type 2 diabetes or type 1 diabetes, and could that cause an area for a super infection? This review of the literature here showed that dexamethasone can increase this risk when compared with the placebo. They did not have great data about methylprednisolone or hydrocortisone. The adrenal trial, which isn't specifically listed on here, but was seen in the meta-analysis, found no statistically significant difference at a 90-day mortality between hydrocortisone and the placebo. And so take that what you will. Just generally, kind of what we talked about last week is that if you have a patient who remains unstable, think about reaching for steroids. Weigh in your mind if this is somebody who is going to have a complicated course, complicated by hyperglycemia. And if you're going to reach for something based on this literature review, they would recommend hydrocortisone at 50 milligrams IV Q6 hours for refractory shock once you've on 2 pressors. Shakira, I see your hand is raised. What's up?
Yeah, I was going to ask actually, because this is something that I think I often forget to do, to be honest. And so I was wondering if you have some way that you remember, or like what part of the treatment course do you say like, okay, now I'm going to remember steroids along the, like, in my mind, I always think fluids and then vasopressors and then call the ICU. And I feel like sometimes I get lost in there and I don't actually frequently start steroids early enough, I think.
Sure. I mean, as we talked about in our lecture last week, if I'm chart reviewing a patient and I have a higher suspicion on somebody who has an autoimmune disease or is already immunocompromised, I'll start them a lot earlier, like halfway through. If I'm up titrating my vasopressor, my first line agent, if I feel that I need a second line agent because they are just not getting the correct response that I want, I will sometimes have that conversation with my MICU fellow to see like, hey, I'm considering putting this on here. They don't have, crazy diabetes or anything. And I think that it could help.
Yeah, thanks, Julia. That sounds good. Honestly, I feel like I should do this more because it seems so low risk considering all the other meds that we do that have higher risk. So thank you. I'll add this to my...
Yeah. And then further going off of this, there isn't actually a big change in the length of stay for ICUs based on this meta-analysis. It shortens it by about a day and the whole hospital course by about 2.5 days. So in the larger scheme of things, what does that mean? It is not a lot, but if you are having somebody in refractory shock, it's not a bad thing to have in your pocket. Okay, guys. Case 2, can I have a new volunteer? Because Dr. Bowman folk did great on that first one. Those are hard shoes to follow.
Before someone volunteer, can I have a question on
of
case
course.
1? You mentioned about corticosteroid in the sepsis shock. Can you make it clear, or can you tell more about how you practice in the US? That when you consider to start corticosteroid on the sepsis shock patient?
Sure, of course. So going back to this, and somebody who you identify early is in septic shock, you first trial your fluid bolus while you're getting all of everything mobilized. You're placing your lines that you need to. You go back and you reassess. I normally give the fluids, over about half an hour to an hour, and then give them another 15 minutes if they're still hypotensive or to the point that they're getting altered. I will start a vasopressor earlier. Norepinephrine, if I go back and we're up titrating the norepinephrine more than 3 or 4 times and you're still not getting any response, at that point I would reach for a second vasopressor, and at that same time go back and chart review and see if there's anything that I'm missing. Like we talked about, like an autoimmune disease for which someone might be requiring chronic steroids, or who might be steroid responsive if they're in a crisis. What's it called? Scleroderma, like renal crisis. If there's something that's going on that they might need those extra catecholamines that are depleted in their shock state. But if I'm reaching for a second pressor is when I will start thinking about throwing on steroids. Is that clear?
Yeah, it's a really good answer, actually. Thank you very much.
Okay, good. I'm glad that one was helpful.
Can I ask that how long that you usually treating your patient in you are working in the emergency department, right?
Mm-hmm.
Yeah. How long that you take for, like, for example, one sepsis shock patient before admit the patient to
How long do they have to- I remember how long I decided to ICU
average, the patient
so unfortunately the contraction are whereas here we have a nice relationship with our ICU team where they help us in the emergency department, so I don't have to be as hands-on with these patients.
Thank you for sharing.
Yeah, of course.
And actually, maybe I can ask a question because I don't remember how it works in Vietnam. So just like Juliet mentioned, we'll manage the patient, and then once we know that they need to go to the ICU, we'll call the ICU doctors. They'll come down and admit the patient, which functionally means take over their care. Sometimes, though, if they're busy, that can take many hours. So we go through and we treat them for, ideally 4. That feels really short to me. Sometimes it goes up to 8, 9, 10 hours that we're managing them with all the other things going on. So they might functionally be in the emergency department, but there is another team who's taking care of them. In Vietnam and where you work, does the patient get transferred over to care pretty quickly, or do you manage them for a long time in the emergency department?
I am working in Thống Nhất Hospital, Ho Chi Minh City, and it's quite same in Vietnam. Since we take care of the patient for average 4 hours. And it's very rare that we have to keep the patient for like 8 or 9 hours. Since quite similarly, we have a very good relationship with the ICU. So they will try very hard for arrangement so we can admit the patient quickly. But the ICU doctor won't go to our department for consultation, or at least for consultation, not for treating the patient themselves.
Mm.
Yeah.
Okay. Yeah, perfect.
Yeah, I'm Dr. King. I'm working in EMC. So our hospital always full of patient in in patient clinic. So the patient usually stay in our department very long, sometimes 2 or 3 days. Yeah. So sometimes severe patient need to admitted to ICU, maybe stay in our department 2 or 3 days. Yeah. Okay. I also have a question. Do you often have patient sepsis, patient or septic shock, patient with Cushing syndrome? Yeah. In our department, I have many patients with severe sepsis, with Cushing syndromes, due to they take medicine for pain. Yeah. So with this patient, we usually give hydrocortisone really early. Yeah. Yeah.
To help with pain management, Dr. Keat, or that you just know that they're going to stay with you guys for a long time?
Yeah.
Oh, okay. Okay. Perfect. Thank you. Thank you all for sharing. Yeah, it's very interesting to hear how different people are managing their patients in their departments. And I'm sorry, Dr. Keat, if you're keeping your ICU patients for 2-3 days, that sounds very stressful, especially if they are very, very sick. I'm glad they have you to take care of them. So, are there any other questions before we move on? No? Okay. So let's do a second case. I will read this one. It's a 29-year-old female who's coming in with very non-specific symptoms of fevers, chills, and body aches for the past week. They're pretty tachycardic at 165. They are hypotensive, 84/58. They are breathing pretty quickly at 35 a minute. They're febrile to 39.1, and they're saturating 89% on room air. And they weigh approximately 100 kilograms, a little bit of a bigger person. So with that information, if someone could please help me with the differential diagnosis.
Maybe sepsis with unknown origin, and in our country, a very familiar diagnosis is the dengue fever.
Yeah. So it sounds like dengue fever. I know we talked about that last week, that that you see that a lot over there. This patient, if we were to think about other differentials that we don't want to miss, and somebody who hasn't been feeling well with very nondescript symptoms, looks like they're in septic shock or at least moving that way, pretty tachycardic. What other things do we have to think about besides dengue fever or pneumonia? Okay. So again, the list is pretty long. So until anybody says, otherwise, you still have a pretty broad differential until you start getting your information back, or until you put an ultrasound on, or you have any definitive imaging. I don't think that she was having any abdominal pain from the short vignette I gave you, so less likely an intra-abdominal process. However, as we said before, any young person with the uterus and who comes in hypotensive could be an ectopic pregnancy, could be a ruptured ovarian cyst, it could be a missed septic abortion or retained products of conception until proven otherwise. Other things for her, she was very tachycardic and hypotensive. Something I would also be concerned about, even though she's young, if we don't have a lot of her background history, is thinking about something like tamponade or an obstructive shock process, especially with slightly, she's not saturating well on room air. Less likely a pneumothorax, but it could be, very large effusion that's causing her to still have some tamponade physiology, or tension physiology because of the size of a possible effusion. So just thinking that you still have to think broadly. So she's speaking normally, but she's speaking in shorter sentences. She's tachypnic. She has clear lung sound, so less likely a large effusion, isn't using accessory muscles, and she's warm and diaphoretic. A little bit more information. She's 29. She's here with subjective fevers, chills, and diffuse body aches for the past week. 3 days ago, she was seen by a primary care physician and told she likely had the flu and was sent home. She's come in with worsening of a dry cough, but doesn't have any sputum or hemoptysis. Otherwise, review of systems is negative. With a little bit more history, what interventions, medication?
Some oxygen and 2 large bore IV, 30 millimeter fluid per kilo in the first hour, some blood tears, and I also want to give her something for her fever, like antibiotics like acetaminophen.
Okay, perfect. And then is this somebody, I know the dengue prevalence is very high there, but is this somebody who you would think about doing antibiotics for right off the bat, or is this somebody that you feel like maybe we could wait for them?
I think we should wait until we find the source of her infection first.
Okay. I see. So I agree. We talked about the 2 large bore IVs. We talked about placing this patient on oxygen because she has a lower oxygen saturation. We talked about the antipyretic. We talked about an she's not vomiting. Sorry, this one was carried over from the last one. Talked about maybe some imaging, some blood cultures, urine cultures, a lactate, blood gas is something that I would add, urine pregnancy, and an EKG and your coags for this patient. Your physical exam, this patient is ill appearing. They have dry mucous membranes, so we're glad that we gave her fluids. She's tachypnic and tachycardic. She does have a murmur. Her extremities have kind of thready distal pulses, and along her skin, you notice scattered petechiae on her lower extremities, and that she's diaphoretic. This is her EKG. Do you have any concerns with this EKG?
Besides of the raised everything and it's looking normal to me.
Yeah. Yeah, I would say like maybe some possible non-specific, possible lengthening of her QTC and like lead 2 and some non-specific changes in V3, but nothing that is consistent across multiple leads. This is the chest x-ray that you obtain.
It looks like pneumonia to me.
Yeah. Is there anything specific about this chest x-ray that makes you think of a specific type of pneumonia? Besides that, it's multifocal. Oh, I think we might have lost him. So if you also go and you put your ultrasound probe on, and this was your cardiac view.
Does it look like an endocarditis?
Yeah. So it's a thickening of that anterior mitral valve leaflet. And now if we go back, and if you looked at that echo and you look at this chest x-ray, instead of just a specific multifocal pneumonia, I would be concerned about septic emboli. So we have these things and we go to our labs. Is not no leukocytosis, but does have a left shift with 20% bands, going back to our SIRS criteria of more than 10% bands. She's not anemic, but her platelets are 3. She has a metabolic acidosis, as well as it looks like a very severe acute kidney injury. She has a slight transaminitis, an elevated T-bili, and her blood gas is listed below. Are there any other interventions or additional lab tests or additional concerning diagnoses that you have at this time with these lab values?
That's a really high lactate.
Yes, it is. She's very sick.
At this point, I really want to get some antibiotics. I have no experience with septic embolus before, so maybe I use something broad spectrum like Diploma.
Sure. Okay. Yeah, I think that's a great idea. I agree that she needs antibiotics sooner than later. As we talked about last week, and it's kind of hospital specific. At our hospital and most of the hospitals in the US, we do like the 1 hour, the 3 hour sepsis bundles for early broad spectrum antibiotics with the thought that you can decrease your antibiotics or specify them when you get your cultures coming back. But I agree, this is someone who is sick and has septic emboli, and they're now showering into her lungs and probably other places too. What I'm also concerned about is, yes, she has a high lactate. Yes, she's acidotic and acidemic when you're looking at her blood gas. She also is hypoxic, as we see on her blood gas, and it's a primary metabolic and not a respiratory acidosis. And going line by line, she has the left shift, so we're giving antibiotics. She's not anemic, so we don't need to give a blood transfusion. Her platelets are 3, so in a patient with sepsis, I get very concerned for either like a ITP, a TTP, or a DIC picture in somebody like this. It looks like she's got some pretty significant kidney injuries. And is that due to microthrombi that are being thrown into her kidneys? Or is that because she is having such poor perfusion that now she's having additional ischemic injury to her kidneys because of poor perfusion and she needs more fluid? And it looks like her just going off of the ratio, it's not quite pre-renal, so I don't believe it's a fluid down issue. And then going over to her liver, is this the formation of a shock liver state with these rising transaminases, where we're concerned because she's hypotensive or having microthrombi that are being thrown into her liver? But what really concerns me with this low platelet count and this high T-billy is that she might have the beginning of a microangiopathic hemolytic anemia. Is that something is chewing through her coagulation factors? So she's got she has an elevated PTT on here and a slightly elevated PT, but her INR is normal. So things that I would also send off in addition would be 3 blood cultures. So in endocarditis, you have to be concerned with culture negative HACEK, HACEK. So often we'll get the 3 blood cultures with our patients with endocarditis, and then also DIC labs. So our DIC labs for this patient, she's got a pretty elevated D-dimer. Her fibrinogen is low, which is something we get concerned about in DIC, but all her other coag labs are normal. So this is a pretty sick patient. So I agree with you. We gave her antibiotics, and then we're going to talk about DIC for a moment, and then we'll go back to her. So what do you know about DIC besides that it's bad, and especially in patients with sepsis? You can use the
pretty much not a lot of things beside it. When it happens, it's very bad for the patient.
Yeah, I agree. So I personally have only seen it twice. Shakira or any of the other doctors who are on here, if you've seen it more than twice, please jump in. And one of them was in the setting of a patient who was pregnant, which is the number one cause of patients going into DIC is pregnancy, and the interface of the amniotic fluid interacting with your blood vessels, which causes the platelet cascade to start becoming hypercoagulable. And then you actually churn through all of your platelets to the point that you become hypocoagulable. Things that I was not as quite aware of and are not on my radar as much are that you can have chronic DIC, which is usually seen in patients who have pulmonary embolus. They just have suppressed fibrinolysis. So they're mostly in the hypercoagulable states, which is when you'll start seeing patients with pulmonary embolus, and they'll kind of be in this chronic low state of DIC, not to the point where they are oozing from any of their IV insertion sites, but just that they are at that hypercoagulable state, which would be worked up as an inpatient. But in acute DIC, you're seeing this enhanced fibrinolysis. So they're getting that excessive coagulation and then the breakdown of those products. So you get the bleeding symptoms that are predominating in acute DIC, like in sepsis. There's no absolute criteria for DIC, but there are two major scoring systems. If you are using either one there, I'm not sure if you in Vietnam use the JAAM. It's the Japanese Association for Acute Medicine for DIC. It actually has a little bit of a higher sensitivity than the ISTH one for overt DIC. Just if you look at it, it's has a little bit broader specifications, and a little bit more sensitive to catch DIC earlier than for the ISTH. Just looking at the different platelet counts, if you're starting to look at, when the platelets are less than 80 versus when they're less than 50. So things that we normally order, you look at your platelets, you're looking for any new thrombocytopenias, looking at the PTT, looking at the fibrinogen, the cutoff for starting to think about repletion is 100. Ideally, you want your fibrinogen in patients more than 150. If your patients have any of the SIRS criteria, complicating by sepsis, then it makes them at higher risk of DIC. And anyone who has greater than 4 points for the JAM DIC panel or 5 points for the ISTH, you consider them having DIC and start thinking about treating them supportively. As I said, number one is normally caused by obstetric complications. Number two is infection, usually sepsis, usually gram-negative organisms, because the gram-negative endotoxins cause exposure or they're activating the tissue factor in endothelial tissue cells. And so any condition that causes ischemic tissue injury or that exposes your coagulation, so your platelets to release tissue factor. So if there's any vascular injury can also, like in trauma settings, can cause DIC. It's less likely, but it's normally infection or obstetric complications. And we can go on. So this is also just something my program director, when I was in residency, always said, don't ignore new thrombocytopenia, because, the possibility of it being a DIC or a TTP where you need to intervene is pretty high. It's a bad mortality, bad outcome if you're missing something like that. So looking at the smear, looking for any schistocytes, and then looking at those secondary coagulation factors that we talked about, like the fibrinogen, and looking for the D-dimer. So your next steps, we're going to treat the DIC. At what platelet count are you thinking about giving this patient platelets? Is there a certain number where you would transfuse her, or would you wait and see or think about steroids? What would be your course of action for this patient who's in your department?
We actually have never encountered actual DIC case. We have one, but unfortunately the patient died in our department, so we haven't managed to transfer the platelets or anything else. But I think in this in this patient particularly, I want to transfer the platelets because her platelet number is very low, and there's some fatigue in her lab.
Oh, Dr. Nunley, I think you muted. If you were done with what you were saying, that's okay too. But I agree. So I would transfuse her. Normally our cutoff is 10 if they are not bleeding, and then less than 50 or 50,000 for whatever your units are at your hospital. if they're bleeding and it's less than 50 for your platelet count is when you think about transfusing platelets. Also thinking about secondarily if you need to start initiating FFP based on what the fibrinogen level is to help support her coagulation cascade. And then knowing that this is now a primary cardiac process, it looked like her squeeze was doing pretty well, but I do think that knowing that this is a cardiac etiology, you have to think about your fluid management. So this is somebody who, you give the first fluid bolus, but if they are still in refractory shock, going a little slower with your fluids and then reaching for that vasopressor early. And then who would you call at your hospital to have the discussion to help continue this patient's care?
Usually I would transfer to the ICU for sure, but if she does have the endocarditis, so we usually have to consult the surgeon first.
Yeah, I agree. And as we talked about before, it's hospital dependent. Here in the United States, it's often the cardiothoracic surgeon, and they want often a formal transesophageal echo to see the size of the vegetation. And if it's greater than 10 millimeters, they'll go in and they will remove it versus trying to find that balance, like we were talking about last week, of just managing medically first. So good job. And then this one is open for everyone to answer in the chat box. Which of the following is a major modified Duke infective endocarditis criteria? So I know this is a very specific question, but looking for, when endocarditis is on your differential, are we thinking about fever, a history of IV drug use, the Osler's nodes or Roth spots that you can see for cutaneous manifestations of those septic emboli? Is it that you have blood cultures that are positive, or that you have septic emboli seen in either a brain scan or on the chest x-ray? Okay, I have two answers that say D. Perfect. Exactly. Yep, D. So the other four are minor criteria. And this is something that you don't have to know off the top of your head unless you are taking any board studies or having to answer any board questions. But just thinking about the major criteria are kind of intuitive. If you are having a positive blood culture, if you see on your echo that you have an obvious vegetation or an abscess, if you're hearing a new murmur where your patient has been seen and documented pretty recently or pretty well in the past to not have a murmur present, or your minor criteria, fever is pretty nonspecific, but if you're also seeing evidence of septic emboli, one would think it's a major criteria, but it's a minor criteria in case it's the site is from somewhere else. And then, definitive endocarditis, it's a mix and match between either two major clinical criteria, a major and three minor clinical criteria, or five minor clinical criteria, or on histological findings if someone goes in and takes a biopsy and they send it to the pathology lab and it comes back concerning for a primary cardiac vegetation on there. Okay, so then this is just the modified Duke criteria and slightly more colorful picture. We know that risk factors include, as this patient, a structural valve issue. Likely patient had rheumatic fever in the past and had some issues with their mitral valve, which predisposed them to growing vegetations on there and to endocarditis. Patients with prosthetic heart valves, patients with IV drug use, patients with indwelling catheters, so your patients with ESRD or any PICC lines that can seed off and then cause additional vegetations on the valves, or recent invasive procedures also are at higher risk. Left-sided or the mitral valve is more common versus, the right-sided involvement for patients with IV drug use for tricuspid, and that one's normally Staph aureus. We were talking about which antibiotics to use initially, vancomycin and then gentamicin is suggested, but based on what your hospital has available and kind of what the sensitivities are for the antibiotics at your hospital, it might change. And then the second picture says for the timing of surgery and the size of the vegetation, if it's greater than 10 millimeters, based on which guideline they're going off of, and how ready your surgeon is to take your patient to surgery kind of differs also. Unfortunately, it's surgeon dependent on how quickly they take them to the OR, but anything greater than 10 millimeters is likely to require surgical intervention and kind of scraping the valve or a complete valve replacement. So we talked about the risks. Let's get a little bit more into the treatment. Treatment can depend and changes based on native valve versus prosthetic valve. So vancomycin or daptomycin, depending on what your institution has. If your patient has concern for septic shock, also add cefepime or gentamicin. With the prosthetic valve, you want to add on a third anti-pseudomonal agent because you won't get this anti-pseudomonal coverage with the gentamicin alone. So vancomycin, and then they want cefepime and also in addition to the vancomycin and gentamicin, whereas a lot of times for our broad spectrum antibiotics, it will be vancomycin and cefepime. If somebody has a history of IV drug use and you're seeing that vegetation on a tricuspid valve, or you have skin evidence to suggest that there is a history of IV drug use and you're concerned for endocarditis, you do vancomycin or daptomycin because you're more concerned with Staph aureus coverage. Okay, last question. Consider giving FFP in DIC if A, your INR is 1.5, your fibrinogen level is 60, your PTT is 30, or your platelets are 75. Okay, I've got one that says B, one that says A. Okay. So the correct answer is B. So we're looking at this second column for when to give FFP. If your INR is greater than 2, that one was 1.2. If your PTT is 2 times the normal, or your fibrinogen is less than 100, kind of what we talked about with our patient earlier. And then the dose there is 15 to 30 milliliters per kilogram, or 1 unit of FFP is about 250 mils. And then when to give platelets, we touched on earlier. So some people say less than 20. They definitely say less than 10 if the patient's not bleeding, and then less than 50 if patient is actively bleeding. So great job, everybody. Ooh, that went much faster than I wanted to. So our summary is always keep a broad differential for your patients with septic shock. Consult your surgery colleagues early for source control. I know it's difficult at all of our sites sometimes to manage balancing a patient who's tenuous with their septic shock state when they really need source control. Consider endocarditis when you have some cutaneous manifestations, vague symptoms, and then pull out your ultrasound early. If you do have endocarditis, you're going to need 3 blood cultures, very broad spectrum antibiotics, and hold a high suspicion for DIC, especially in any new patients with new thrombocytopenia. So type and cross your patients early so you're not having to play catch up later. Are there any questions?